Good morning, everyone. I am Dr.Suhaib Ali. I will lecture about persistent epithelial defect when the defect does not heal. A few points about the anatomy of the corneal epithelium. Several layers. Most important is basal layer of single columnar mitotic capability and with hemidosposome with basement membrane. Most important is the basement membrane adhesion to the underlying common layer by anchoring fibrils. Physiology, corneal epithelium takes nutrients from the aqueous humor and oxygen from the tear film. Turnover, according to the third hypothesis, centropedal migration of limbal stem cell toward and the superficial migration should equalize the desequamation process. Epithelial healing process after corneal abrasion starts in several steps, starting with migration, either it's an active or non-active phase, then proliferation takes 36 to 48 hours, and finally, which is most important, is the adhesion, either temporary after 48 hours or permanent, which take up to 1 to 6 weeks. Keratocyte response to the injury, starting with the secretion of interleukin-1s and several growth factor. These growth factor are highlighted because of importance of subsequent novel therapies that target them, like hepatocyte growth factor, keratocyte growth factor, and also insulin-like growth factor, transforming growth factor beta, and platelet-derived growth factor, thymosin beta 4, and nerve growth factor. The persistent epithelial defect is a failure of the mechanism of promoting corneal epithelialization with a normal 2 weeks time frame, even with standard supportive therapy. Underlying etiology, variable etiologies, starting with epithelial disadhesion, limbal stem cell deficiency, and also idiopathic and hereditary, and also inflammation, neurotrophic state, and mechanical. The treatment is severity-based and directed toward correctable underlying condition, providing appropriate nutrients for reepithelialization. We can conclude from neurotrophic state classification that in the stage 2 moderate state with persistent epithelial defect, the visual impairments start to compromise, which can be more severe and dramatic in stage 3 with stromal scarring and ulceration start to occur. What consequences of untreated persistent epithelial defect is increased risk of infection, scarring, vascularization, and perforation, and finally visual loss. And the persistent epithelial defect should be treated within 7 to 10 days and aggressively after 10 days to prevent the stromal fibrosis. We can classify the epithelial defect either simple epithelial defect less than 2 weeks duration and persistent epithelial defect when more than 2 weeks duration on supportive therapy, and refractory persistent epithelial defect when it is take more than that on supportive standard therapy. Stepwise approach, starting with patient with persistent epithelial defect to test corneal sensation. If it's normal, it's a neurotrophic state, unlikely to exclude this important subject, and if it's abnormal, it's also need confirmation because it also may be compromised in other states. When we had a persistent epithelial defect, start with standard therapy by treating underlying condition like diabetic keratopathy, limbal stem cell deficiency, and systemic autoimmune disease, excluding iatrogenic causes like toxic topical medication and preservatives that disrupt epithelialization, and starting with initial therapy with aggressive application of preservative-free every 1 to 2 hours, or putting a bandage contact lens. Punctal plug can be placed to retention of normal natural tears, and topical and systemic vitamins like B12, A, and E, and C for sure with the prophylactic antibiotic. Vitamin B12, it's escalating today because of bariatric surgery and strict diet. Also is deficient in patient with diabetes. Supplementation with systemic and topical therapeutic dose that's cause dramatic response regarding keratopathy after 3 weeks duration. Topical vitamin B12 also available in the markets, while vitamin A and E also available in the markets, which is also a part of the autologous serum. Dexpanthenol also have some role in patient with persistent epithelial defects after refractive surgery. While refractory cases, though more than 2 weeks and not respond to the standard therapy, we can start autologous serum either 20% for mild cases or 50% for severe cases. Then another option is the platelet-rich plasma fibrin. Also, scleral contact lens or prosthetic replacement of ocular ecosystem can be worn overline to target the abnormal healing process. While surgical options like debridement of the edge of thickened and healthy the epithelium to allow reepithelialization. Also, temporary tarsorrhaphy is important here, an option because it's a low examination and topical application of the medication and quite simple procedure. Amniotic membrane is an option in persistent epithelial defect, while last resort the transplantation of corneal epithelial limbal stem cell or keratoplasty or finally Boston keratoprosthesis. What is the difference between platelet-rich plasma and autologous serum? It's highly concentrated with, it's just the thin layer of platelets have an 8 concentration that what we found in the serum. Several growth factors over the autologous serum available also can be quite important in cases with systemic autoimmune disease, which autologous serum is quite harmful and should be diluted too much. POSE is prosthetic replacement of ocular ecosystem, also an option here. Restore vision and promote epithelialization is FDA approved for healing of irregular cornea, which worn over 24 hours overnight and last for 48 hours after epithelialization. It is quite effective and safe. While novel therapies coming in the markets, several, why they are novel therapies is an option because several previous therapies targeting mechanical support, while these medical therapies developed to target the epithelialization process by facilitating access to these specific growth factor that's secreted during the healing process, and anti-inflammatory agent as well as a new surgical technique. Fibronectin is a glycoprotein important for adhesion of the epithelial to the basement membrane. Conflicting results in some shows positive result and other disagree. Thymosin beta-4 is a small peptide promoting reepithelialization, available in the market as an oral supplement used in angioedema, decrease inflammation of matrix metaproteinase. Now it's in phase 3 clinical trials by Regeneron. Nexagon is antisense oligonucleotide, downregulate the connexin and overexpressed naturally connexin in chemical or thermal injury. So decrease inflammation and edema, quite important in persistent epithelial defect after chemical injury. Also available at phase 3 clinical trials, which coming soon in the market. Epithelial growth factor had stimulation effects of limbal and peripheral stem cells, promote epithelial proliferation. While insulin growth factor is commonly used in our locality, induce migration and proliferation of corneal epithelium and promote limbal stem cell differentiation. Topical concentration of 0.5 to 1 unit per drop used for daily, quite important in eutrophic state. The human growth factor shows, in most models, show no substantial effects. Albumin growth eye drops is the major constituent of the autologous serum and can be benefit in treating ocular surface disease like alkaline chemical burn or graft versus host disease and exposure keratopathy. Matrix regenerating agent RGTA available in the market as Plasticol. It's replaced heparin sulfate and effective in managing neurotrophic, better to be applied over bandage contact lens. Amniotic membrane extract is more concentrated growth factor than topical autologous serum. Promote also corneal epithelial and limbal stem cell differentiation. Recombinant human nerve growth factor like oxervate, all we know is FDA approved. Sinagermine, according to the REPOWER study, 10 to 20 microns 6 times daily for 8 weeks. And lastly is corneal neurotonization. So another option is surgical management of persistent epithelial defects should be not the last resort only, should be applied at appropriate time being. Like surface stabilization with punctal plug can be used in initial therapy, or surface reconstruction like correction abdominal malposition and amniotic membrane graft, which can be inlay or overlay patch or graft. Enhanced revitalization with 6 weeks to and promote the wettable surface in 3 months. Also tarsorrhaphy, so which is amniotic or tarsorrhaphy, according to this study, the amniotic, the tarsorrhaphy in group 1 shows faster healing time and also than the amniotic membrane. And surface healing process like new vascularization is only superficial, while both superficial and deep in amniotic membrane. Also, in office-based use, suture-free amniotic membrane device like Procera or Omnigen also available in the market and induce healing within a shorter period of time. Cryopreserved or dehydrated, according to the FDA, cryopreserved retain its all benefits of growth factor and can promote epithelialization process, while dehydrated type is FDA approved for just wound coverage. So to be realistic, finally, when we had a persistent epithelial defect, we can start with lubricant, preservative-free, topical and systemic vitamins, patching an option, punctal occlusion, the therapeutic soft contact lens, and eliminate toxic material. Then if it's refractory, we can start topical insulin combined with autologous serum or platelet-rich plasma. And finally, we can apply tarsorrhaphy and amniotic membrane, either isolated or in combination. And thank you.
Thank you.